Well, welcome everyone. We're glad you could join us for our conversation today. It is focused around AMA's National Minority Health Month Lunch and Learn panel. And that is the month we're in, so we thought it would be great to do this today. Today we'll be discussing partnering for health equity, and we have a distinguished panel with us. You'll hear in a moment. They will be formally introduced. From then, we'll learn about National Minority Health Month and what it's all about. We'll hear how local physicians manage patients and with prediabetes. And we'll discover what organizations are doing to improve health outcomes for minority patients. Moderating the discussion will be none other than Dr. Christopher Holliday, AMA's Director of Population Health and Clinic Community Linkages. Christopher leads a multidisciplinary team that develops and implements national, clinical, and public health strategies for improving health outcomes and reducing costs for high-impact chronic medical conditions such as cardiovascular disease and type 2 diabetes, which, as you all know, the AMA is very focused on. So, Christopher, I will turn it over to you. There's a third panelist not here yet. Hopefully they'll get here in time to be engaged with the rest of the panel. Thank you.
Thank you. Hello, everyone. I am back again, Christopher Holliday from the Improving Health Outcomes Group. It's my pleasure to be here today and to moderate this very important conversation. It is National Minority Health Month, so let's celebrate it together. This is the second in a series of conversations that have been set up by J. Maury Johnson, who is in our physician and engagement group. And I want to just acknowledge her good work and that of her team. J. Maury, I think everyone knows her. Can you just stand for me? J. Maury Johnson has been phenomenal with her team, with Craig, and then Pam from ECM, obviously from Rod, and Tanya and my team have been doing amazing work, and all of you that have been part of both our diversity and inclusion work as well as our health equity work know the quality of the work that they've been leading. In fact, there is a report that's right in front of you that I just want to call out before we get started. This is the 2017 Diversity and Inclusion Report on all of the great work that has been happening here at the AMA. So many of you might not be aware that AMA has two major efforts in diversity and inclusion and in health equity that have been work groups that have been moving forward for the last couple of years, but they help to coalesce all of the great work that you're doing in your respective business units. And we bring all that together, and then we turn the lens toward health equity and diversity and inclusion and how you can do better in your development of your tools and the doing the work that you do every day, with the thought that how does this improve disparities, gaps? How does it lessen those gaps? How does it improve outcomes, health outcomes, for example, for people who are underrepresented minority communities or who represent those communities? So we're very excited for their work. Just to dive right in, I want to just show a couple of slides really quick just to frame the day, and then we'll turn it over to our distinguished panelists. We will not go through their bios. That's why you have their bios in front of you, because that'll take too much time. Just know they're very important and very smart. I will say their names, but we'll hold off on that. Just to kind of frame the way that we're thinking about the conversation today, I just really want to start with what is National Minority Health Month. And it is a month that comes out of our Office of Minority Health that's under Health and Human Services. And April is designated as that month that we celebrate National Minority Health Month each year. It's a time to learn about the health status of racial and ethnic minorities, underrepresented minority communities, and ways that we can together improve their health outcomes. This year's theme is partnering for health equity. So we're talking about how do we join forces with other groups, other organizations that are doing work like we're doing, that can amplify our outcomes, that can really expand our reach into these communities and help improve their outcomes. And those are not just in the clinical setting, but federal, state, local, tribal, territorial, and other communities. So we're thinking about all of those who might be disproportionately impacted by chronic disease, for example. So we're gonna do some what ifs. We're gonna dream big. What if, are you with me? All right, this is call and response, remember? What if we dream big and we could, together with our partners, have the greatest public health and healthcare success of our lifetime by being able to state together that there are no new cases of type 2 diabetes? Would that be amazing? Would you dream with me? All right. So why not? Why not do that? So we're taking that charge on in two specific areas around diabetes, type 2 diabetes, and around hypertension control. So cardiovascular disease and type 2 diabetes within the Improving Health Outcomes group. So let's just take type 2 diabetes. I think most of us have an idea of what it is, but how many people can give a quick definition of diabetes? That's why I put it on the screen. All right, so blood sugar, it's sugar, blood sugar. Glucose is the main source of energy in our body's cells. It is controlled by insulin, and insulin comes out of our pancreas, quick and dirty. But what we might not know is that diabetes is when those blood glucose levels are higher than normal. You ever heard someone say they have a touch of sugar or sugar diabetes? In my family, that's something that was repeated occasionally, and I never knew what it meant until I came to the AMA. No, I knew before. But type 2 diabetes is the most common form of diabetes. There's type 1, that's congenital. Most people are born with it, and there's type 2. And we think that we can come forward with our partners and say no more new cases of type 2 diabetes. We hope that's in our lifetime. So here's what we're doing in improving health outcomes, just to frame this up, and then we'll turn it over to our panelists to talk about their work in this space. So we're partnering for prevention. What we're doing is there are 30 million people with type 2 diabetes, 30 million US adults across the country with type 2 diabetes. Yet there are another 84 million adults with prediabetes. Prediabetes is a condition where your blood sugar is high, but it's not high enough to be diagnosed as type 2 diabetes. So you're on the pathway toward type 2 diabetes if you do nothing. If you don't change your lifestyle, if you don't eat better, you're going to end up with type 2 diabetes. So we're trying to get ahead of this curve. If these 84 million people convert to type 2 diabetes, that's going to cripple the US healthcare system. So the AMA, along with the Centers for Disease Control and Prevention, and all of our other partners are joining forces to get ahead of this curve. We're trying to assure that everyone with prediabetes is aware of their status. That means when you go to your doctor for your annual physical or if you present for something more acute, and he tells you that your blood glucose level is a little high, that's a signal. If you got a little bit of extra around the midsection, or you've been sitting or eating French fries and the things that we eat every day, then you might be at high risk. Racial and ethnic minorities are at higher risk for type 2 diabetes. So there are risk factors that lend themselves to type 2 diabetes. So you may be in this stage. So we're encouraging everyone in America to take a risk test. This is either paper-based or it's online. You can find it through our website. It's 8 questions that can tell you how high risk you are for progressing to type 2 diabetes or if you might have prediabetes. Our campaign, our rally cry with CDC is Prevent Diabetes STAT. STAT is something that resonates with organized medicine. It's a sense of urgency. So we're trying to convey that sense of urgency. STAT stands for Screen, Test, and Act Today. The key there is acting today. If you have high blood glucose and you know you have some of these risk factors, don't wait till your doctor tells you have type 2 diabetes. The time to act is now. These are just some of the healthcare organizations that we've been working with over the years, large integrated delivery systems, all the way down to private practice, making sure that everyone has the tools and resources they need to screen their patients for type 2 diabetes or for prediabetes and make sure that they get into a diabetes prevention program. These are evidence-based programs in the community, at your local church, at a dealership, at your hospital that you can go to and take classes and learn how to improve your lifestyle so that you won't progress to type 2 diabetes. So all of these partners have decided to walk this journey with us so that they can make sure they get to their patients, not the least of which are patients who are underrepresented minority patients who are at higher risk. And here are just some of the campaigns, and then I promise I'm going to turn it over to the panel. You may have seen these billboards, 84 million Americans, maybe even you have prediabetes, person about to fact check this fact. We've got campaigns that are targeted to a low income, communities of color. We just partnered recently with Samsung, where we had in just 6 weeks, 550,000 people through their health app on your Samsung phone to complete the risk test. 550,000 people in 6 weeks found out if they were at high risk for type 2 diabetes. Those are the kind of partnerships we're talking about for health equity that amplify our message, that push it out quickly so that we can get our hands around that 84 million. One of the great things that happened is we worked with CDC, and now the diabetes prevention program that I told you about is covered by Medicare. That gets at another population, so our senior population, who are even at higher risk for type 2 diabetes. So that's my piece. That's framing our conversation today. And now we're going to turn it over to our panelists and ask them a few questions. So we are so pleased today, and I hope that you are as wild and awed as whom we've been able to get as I am. These are stalwarts in the field, and they have done some amazing work. Please read their bios at your pleasure. First is Dr. Neva Lubin-Johnson. She is a physician in internal medicine and private practice. I'm not going to read her bio because we want to hear from her. And then we have Dr. Gary Puckeren. Dr. Puckeren is the president and chief executive officer of the National Minority Quality Forum, and he also works very closely with the Congressional Black Caucus and has an annual Minority Quality Forum, National Minority Quality Forum that he hosts. So we're going to hear from them now. Let's give them a round of applause and make them feel welcome to the AMA. So Gary, can I start with you?
Sure.
All right, no pressure. So you have a little bit of a connection to the National Minority Health Month. You have a little bit of background and how that came to be. Can you just share a little bit with the audience just to talk about why we have this month and how we came here?
So I always confess all my sins before I start anything. So my doctor is actually in history. So so I think of everything in the context of history. Actually, it was National Negro Health Week. It was started by Booker T. Washington in 1914, and he was really dealing with the first generation out of slavery. So in 1914, there were still people who had been born into slavery, who had become free, and at that moment, they had to deal with their own health. And so Booker T. Washington started the program, and it was called National Negro Health Week. Came out at the same time as National Negro History Week by Carter G. Woodson. And that program ran from 1914 to 1945, with the end of World War II. There was some reorganization in the federal government, and the program went away. But there's a deep archive if you go to places like Howard University and other places. All the things that you're talking about now is exactly what they were talking about in 1914 through 1945, with disparities, outcomes. The disparities sort of got lost until about 1985 when Margaret Heckler did a report, that documented the health disparities. And that really launched sort of this new generation thinking about health equity and improving health outcomes for diverse populations. Around Congress, there was some talk about establishing April as National Minority Health Month in the 1990s. There was no formal effort to do it. We picked up the story in 2000, and that was because in 2000, the federal government launched Healthy People 2010, and the idea was to eliminate health disparities by the year 2010. I was new to Washington then, and I was under the belief if our government said we were going to eliminate health disparities in 2010, by God, we were going to do it. And so we looked at it and said, so what contribution could we make? And we got the 103rd Congress to designate April as National Minority Health Month. There are 24 states that recognize and do activities in the month. And the reason for doing it, once Congress passed a resolution, it enabled government agencies to do work in April as part of National Minority Health Month. So if you go to the Office of Minority Health, you'll see that they're doing work. If you go into Department of Defense, they're doing it. All across the federal government, they did it. And we were really pleased. It was a bipartisan effort. J.C. Watts, who was a Republican representative from Congress, did that. And so that's sort of our background. We sort of Congressman Donna Christensen was on the doing the Health Brain Trust, and so we worked with both Democrats and Republicans to get April designated as National Minority Health Month.
I think that's worth a round of applause. Yeah, thank you. Thank you for your work. So let's now frame something for all of our panelists, and I'd like to introduce Dr. Cesar Bastos. Happy that you were able to join us. He's a board-certified internal medicine doc with Alivio Medical Center. Okay, and so let's welcome him. So the next couple of questions I'd like to frame around chronic disease management, and particularly in minority communities in honor of, obviously, celebration of National Minority Health Month. So what are your experiences, either in the clinical realm, in the advocacy realm, or in your research efforts, have you had related to chronic diseases and its impact in the minority community? So think about your respective work, and what have you done, or what have been your experiences in working with and managing chronic diseases among minority communities? And we'll start with Dr. Bastos and move down. Yes, let's push that right here so it turns green. Here we go.
Yes, I've been working with FQHCs since the year 2000 as an internal medicine out of internal medicine degree. The main things that I realized being in 2 FQHCs is that the community has particular cultural issues that are needed to be addressed before we can decide that this kind of chronic disease management will work with them. They have few characteristics like my clinic or the clinic we practice in is 90 to 95% Hispanics, mostly Mexican Americans. Lately, some Venezuelans coming to Chicago. The main medical problem that we have is diabetes. Half of them are diabetics after the age of 50. And we have around another 18 to 25% that are pre-diabetics. They have when they become diabetics, they get their source of information from different places. One is the doctors, the other one is the family, and the community organizations. What I found is that probably the most effective one is that group teaching done by their peers in the community. When we talk about the peers in the community, we don't mean necessarily somebody coming from college. They feel more, they familiarize better with somebody who doesn't have a degree that comes from the neighborhood. The doctors, we don't have the time to do major teaching in 15 minutes of visiting the clinics. The other thing that we have to address is that they tell all the story and sometimes they don't tell all the story. They have a high use of, or we have a high use of supplements coming from the US and coming from Mexico and some other places. Some of them with interactions, hypoglycemias, that they don't disclose initially, but we have to always be open to ask the questions. The other one is that they share medications between the family. They are very united. So if somebody that doesn't have metformin, they will get some glipizide from somebody else. Also, we have a large community that goes back to Mexico for vacation, 6 months, sometimes 9 months, and they come back. I don't have the proportion. Some of them are Medicare, some of them are uninsured. So when they come back, we get the A1Cs, they're 11, 12, and they tell us, I'm leaving to Mexico in 5 days. So they come back later in 5 days, they're 11, 12, and again, I'm going to Mexico again. And they're Medicare. For those of us that are concerned about taxes and how we spend the money, and if we can really, really prevent chronic complications. So those are some of the main issues. The other one is that I think I'm from South America. It took me around, I speak Spanish. It took me around 5 years probably to really, really know the slang, what they mean by elote, full elote versus, I don't know, regular elote. For 3 years, I said, yeah, elote is fine, it's corn, it's great. You can have a couple of them if you want. Until one day I got out of the clinic and there was the elotero. I said, give me one full. And it was the elote plus liquid butter plus cheese plus mayonnaise. So those are the few things that we have to learn. Even being in the same language, apparently we should know everything, but that's not the case. I many times offended people by saying few words that in my country are normal, but in their country are not normal. The other thing is that we have to be humble in order for them to trust us. And we have to empower them and tell them, yeah, what you're doing is right. We have to give a lot of positive feedback. and kind of test the patients how much of a paternalistic approach they want or not. They are not used to this idea of evidence-based. The doctor decides, and you decides the choices, and you will make the final choice. No, they will say whatever you want. So we have to look at them at the same level and recognize that the family is important. Recognize that some of the supplements might be helpful, some of them not. Make a team approach, and probably the most important thing is that, to my surprise, was not to my surprise, I was expecting that, but that Promotoras de Salud, is it the time?
That means you're over. No, did you have a final remark?
No credit for being late?
Okay. We'll come back. We'll come back. Thank you. That was your signal. So let's turn it over to Dr. Luma Johnson to answer the same question.
Thank you and good afternoon, and thank you for the kind introduction. So I have a private practice, general internal medicine. About a third of my patients are seniors. 95% are African American. A lot have chronic diseases. A lot have diabetes. A lot have pre-diabetes. A lot more have pre-diabetes. And so the struggle and the challenge with taking care of patients who have chronic diseases is getting to them that A, it's chronic, but B, it can be changed. It can be managed. You can do better. And so I really try to stress things that are within their control in terms of diet and exercise, getting enough rest, in terms of what you can do to help with the disease, especially with pre-diabetics. I mean, we know that a small amount of weight loss will prevent pre-diabetes from going to diabetes. But in spite of that, I probably have a patient every week who goes from pre-diabetes to diabetes. And it's not because I haven't told them for the past how many years that, 15, 20 pounds of weight loss could prevent you from developing diabetes. And other challenges with that are you hear about time management. It's not easy for a single mom with school-age kids and have to grocery shop and find somewhere to grocery shop and time for exercise, but you have to spend the time to talk to them about how it can be done. And really, I guess my style has evolved from when I started practicing medicine when I was a child 29 years ago.
Baby.
That's right, child prodigy. To, evolving over the past few years for a more teamwork approach. This is what you should do. Let's talk about what you're willing to do now, And if now is especially for a pre-diabetic, you can make some choices about what you eat. Let's talk about adding fruits and vegetables to your diet, okay? And, over half of us don't eat 2 servings of fruit or 2 or 3 servings of vegetables every day. And there are benefits just from doing that, even if you don't take out the other stuff. Study was done, and it showed people who didn't eat fruits and vegetables, lots of inflammatory markers in the blood. Some of this contributes to diabetes. People who are vegans, very little inflammatory markers in their blood. People who ate fruits and vegetables and some of the other stuff we shouldn't, middle. And so there's benefit to just doing that. And so if I can get patients to agree to eating more fruits and vegetables, because even if you don't change some of the other things, you can lower your cholesterol, you can lower your blood sugar, you can lower your blood pressure just by eating more plant-based diet. So, that's kind of an evolution I've had in terms of taking care of patients. It is a challenge. I've got some chronic illnesses. I'm not going to say what they are, but I've got some. And it's a challenge. I did better with some a few years ago than I'm doing now. But it's stress and time management and life and trying to, work those things out together. For seniors, it's getting them to see that just because you're retired, you don't have to sit at home. And there are opportunities, even if you're on a fixed budget, of things that you can do. And even insurers now are giving them things to do to help, because they know that they don't have to sit at home, they can be active, give them opportunities. For, men, You know, nothing personal, guys, but you know, some think they know everything. My husband included. And so trying to, you know, once again say, okay, what can you do? You know, I know you know what to do, but what can you do? And so I think it's kind of, you know, individualizing the plan for each patient in order to help them to see what they can do, what they should do, and be grateful for, you know, the goals that come along the way.
Dr. Puckett.
So the National Minority Quality Forum, what we've been focusing on is data collection. And a couple of quick numbers that help us into this diabetes story. So there are 38,000 zip codes in the United States. 70% of African Americans live in 2,500 zip codes. 70% of Hispanics are in 2,500 zip codes. 50% of Asians are in 1,500 zip codes. So the minority population in this country lives in 7,000 zip codes. All of these disparities and things that you're talking about are happening in 7,000 zip codes. So we've been collecting zip code level data since 1998. We've got a database now north of 5 billion patient records. And in that, we actually know by zip code what's happening. So if you take an African American with diabetes and coronary heart disease, they have a 90% hospitalization rate. On average, about 60% of African Americans, Hispanics with diabetes, either have an emergency room visit or a hospitalization stay every year. Those are the numbers down at the zip code level, and they don't change. Understanding that, we also can see what is happening in the practice, meaning we know what physicians are prescribing, we know if the patients are adherent, we know what the costs are. And so we've evolved to really doing quality improvement down at the practice level, going in and sharing best practices. Not us, but having physicians champion with their colleagues. And we also do a lot of patient advocacy and patient work. One of the things I saw in your update of 17 that I thought was profoundly important was some work that was looking at increasing physician reimbursement for Medicaid. And so here's the story. Because we pay physicians who provide Medicaid services, what they have to do is they increase their patient panel. So it's not unusual to find a physician with a large Medicaid practice who has a 6,000 patient panel. And the point is that best practices say you should have 1,500. And so what you end up doing is you have to cut that patient short. So they're not getting the 15 minutes, they're not getting the conversation, and it has a deep impact on the quality of care that the patients are getting. And so we can see it in the data. And so what I tell everyone, we're like the statistician at the baseball game. We don't go down the field and play baseball. You guys play baseball. What we try to do is collect the numbers and come back and tell you what the stats are saying, because we think quality care is going to be a data-driven issue. Eliminating health disparities is going to be data-driven. And so we have a lot of different working groups, and that's how we sort of get to the issue.
Thank you. Just as a follow-up to that, so I'm going to read a quick set of stats, since you are the statistician in the room, that I think it's provocative, but I think it helps to share the enormity of the issue. The total estimated cost of diagnosed diabetes in 2017 is $327 billion. That 327 is broken up to 237 billion in direct medical costs, and 90 billion of that is in reduced productivity, so work. Just to make that a little bit more plain, care for people with diagnosed diabetes accounts for 1 in 4 healthcare dollars spent in the US. So 1 in 4 go to people with diagnosed diabetes. So this is the enormity of what we're dealing with. In your practice, in your system, in your research, just as a follow-on to what you've just shared with us, what are you finding are some of the biggest barriers or biggest challenges and issues to treatment and management of people with prediabetes or diabetes? You've mentioned a little bit about lifestyle, but what are some of the other barriers that you're encountering? Is it messaging? Is it a sense of urgency? We talk about STAT and the sense of urgency. What are those things that you think are at play that keep these disparities either widening or advancing? Let's do ladies first.
Thank you. So I'd say, in terms of what are the barriers, I think the things I alluded to before, what we now call the social determinants of health, have a big role to play in being a barrier. It's $1 in $4 spent because it's about 1 in 3 or 4 people, adults, who have diabetes. So it's, the dollars are kind of going along with the numbers of patients, and that's why the challenge is decreasing the numbers of patients who have diabetes. It's messaging. I think that if you have, so many in a family and they see it and they think it's a norm, they're not necessarily around to see on an up-close level what that progression of disease looks like. So I'm gonna make it personal. Both my grandfathers had diabetes. My first cousin has diabetes. Her son has type 1 diabetes, different than type 2. My brother had diabetes. My brother died from complications of diabetes. My brother was obese. It was a challenge. He did not do what he should have done. My brother was younger than me, and he has been gone almost 15 years now. He had to have an eye surgery so rare in 1998, I believe, that, does anybody remember who Maurice Rabb was? Maurice Rabb was one of the first licensed ophthalmologists in the city of Chicago, historical figure. Maurice Rabb sent him to St. Louis to get this eye surgery done in 1998. So those are the things, that you see. And I think, unless patients have that up-close personal experience to see what happens step by step by step, they may not realize the gravity, of the situation when it hits them. All they know is grandma had it, she lost a toe. But they don't see those steps that go on until that toe happens. They don't necessarily see that yearly hospitalization that Dr. Puckrin talks about, or a trip to the emergency room, et cetera. And so I think when you start talking about the messaging, but also grocery stores and exercise, and not just groceries, but meal planning. There's a saying that goes, if you fail to plan, you plan to fail. I mean, this is one of those illnesses where you may not need to know every meal you're gonna eat for a week, but you gotta have the things in your house so you can plan it for the week.
That's right.
And so those are the things you have to take into account. Having a support system for when you fall off the wagon, for somebody to say, okay, get up, get back on, keep rolling. So I think, various challenges, insurers, and coverage of meds, covering things that are more convenient for patients to use, that have fewer side effects, as opposed to being told that archaic meds like sulfonylureas really shouldn't be used or prescribed anymore. So, those are more challenges also.
Yeah. We're going to turn it over to the gentleman, but we're going to also open up for questions. So be thinking about the questions you want to ask our experts here. Dr. Bastos.
Yes, I agree. We have some of the same problems in the Latino community. One is access to healthcare. The Latino families in Chicago, especially, they are mixed in the sense that you don't have a family that is all citizens with insurance, and you don't have a family that is all immigrants without insurance and without documents. It's very mixed. You have some kids with documents, some dreamers, some that don't qualify for dreamers, and some fathers or parents that are working with Social Security because they're citizens, and some of them that are working without documents. Usually the men are the ones who have to take 2 jobs and work night shifts. So it's very hard to get a diabetic control when they work night shifts. If it is a single mother also, it's a nightmare because they have also to work night shifts. So access to medications, surprisingly, sometimes they cannot afford metformin. And then when you realize, okay, where's the food then? The other thing that we have is lack of continuity of care because they go to the doctors at the start of the diagnosis to whenever they are sick. They get some diagnosis and they go out of the door, and sometimes they don't get back for the results. And communication, doctors, we don't always get the message to them in the right way. Sometimes we make them understand that, okay, your diabetes is controlled, which means that your diabetes is cured, and they will not come back in 3 years. Besides that, and the other thing is that they don't all know the resources that they have in the community. Some of these things can be addressed at community centers where they have discounted medication, and even then some of them cannot afford the discounted medication beyond metformin and sulfonylureas. So those are I guess the main problems that we have.
Yeah. So we've got messaging, we've got making it personal, helping them to understand that this is not just grandma's issue, but it's something that is very close to home, and you probably have some of the same risk factors as grandma and grandpa and others. Access to medications, access to clear coverage. We've got the Affordable Care Act that's expanded coverage to millions more people, but there's still people who are uninsured and underinsured, so that's an issue. Dr. Puckeren, any other challenges that you would add to that, and then we'll open it for audience questions.
You know, so we tend to look at things at the population health level. And one of the things that when you live in the data, the thing that you become most impressed by, there are no random hospitalizations, particularly for diabetes, meaning highly predictive. I can look at a zip code and tell you how many people are going to, with diabetes, are going to end up in the hospital in a year. How many people are going to go on dialysis with diabetes. And looking at it from those lenses, what it says to us is that there's structure there. It's not just the individual. It's sort of what's happening at a community, and these are output statements from a community. Some of it is related to how people respond to the disease. Some of it's how the practice of medicine. Some of it is how we insure populations and create access to it, and some of it is just risk in terms of the population. And from looking at it from that lens, what we walk away and say is, we want to control health outcomes. If you come to our organization, what we're talking about is controlling health outcomes at the community level. And what we mean by that is, we want the system to operate at the top of its license. We want to optimize health at the community level so that everybody in the system, be it patient or provider or insurer or policymaker, whomever's in the system, they understand what evidence-based medicine looks like, and they're trying to practice it. We think that's what's going to happen in the 21st century. That's where big data is taking us, that more and more the data is going to drive health outcomes in the community. And so the challenge for us right now is to get all that data curated and into practices and into the hands of patients, but that's coming. If you just look at the biometrics right now, there are people the blood glucose monitors that you wear, right? And the data is being pulled up into the cloud. And in fact, I was talking to someone who's actually doing that. He said, you know, if you push that data back down to us, we can do hemoglobin A1Cs at the zip code level and look at how well we're providing care to a community of patients just by looking at aggregated hemoglobin A1Cs. We already do it for HIV. If you look at T cells, that's exactly what we're doing. So I think what I'm saying to you is, we're in the middle of a paradigm shift. And I think AMA has a really big role to play in that. We got to get ourselves out of this presentism stuff in which we just think about healthcare in the moment and what it costs, and not looking into the future about where we're going. And I think where we're going is a place where by the time we get through the end of the 21st century, we're literally controlling health outcomes at the community level.
Very interesting. All right, so now we want you all to talk back and ask some questions of our experts. We've got a question right up front.
Okay, so in reading through your bio, and this is for Dr. Puckeren, and you just touched on the very point that I wanted to bring out, and it's about big data, if you would. So can you give us an example of data-driven health outcome success? And also, there was a question about possibly pushing that data back down. Is there resistance to pushing it down, or why isn't it being pushed back down today, and what will help to move that forward?
So the second part first. Our healthcare system is highly balkanized. It's balkanized because we don't have universal healthcare coverage like England or Canada. And so the balkanization means that the data is held, what I call the feudal lords, the old feudal system. You had to pay a toll booth every time you were trying to move commerce, and that's what one of the things that the king did was remove these feudal lords. And so what's happening with health data, it's being controlled through these balkanized systems, and so we don't have free flow of information. And so it really creates a challenge. Some people don't want it to flow because it impacts their business model for one reason or another. And so I think there's got to be a big push to figure out how do we make the information flow so that we can actually use that data successfully. So the answer of, so can you give me an example of how you've used the data? We've been doing a lot of work with African Americans with heart failure. If you take an African American with heart failure, they have a 240% higher rate of hospitalization than whites. And so we went in and looked at the data, and they're not getting standard of care. They're not getting ACE and ARBs and beta blockers, and there was a fixed dose combination medicine that they were not getting. So we created the performance measure. And what you have to understand, for those who don't know performance measures, back around 2005, the federal government decided that it was going to create performance measures by which to reimburse physicians for care. So a physician has to follow the performance measure in order to get reimbursed for care. So in the case of heart failure, it was an ACE-ARB and a beta blocker, and if you provided those, you didn't get dinged, essentially. They didn't take back some of your reimbursement. The challenge was that all of the performance measures were written for the universe of all patients. They didn't recognize heterogeneity, that some patients needed something different. And so we decided to write a performance measure for African Americans with heart failure. And we moved that through the National Quality Forum. We were able to do it because we had the data, because you can't get a performance measure unless you can show scientifically that there's a problem there. So we moved that through the National Quality Forum, which is a consensus organization that sort of says, yes, this measure should go forward. And by doing that, it then allows insurers to use it in their reimbursement. Now, I'm not one who really likes performance measures. I think it looks like Common Core healthcare to me. I'm not that guy. I think physicians and patients ought to have an interaction and figure out what's best for them, and not have big government kind of telling you what to do. But it was the method that we saw, the best method that we saw to get this improvement for African Americans. So the American College of Physicians, for example, have adopted our measure, and they're using it in their QCDR to report measures for the treatment of African Americans and get reimbursed. And we're working it through CMS. We're hopeful that CMS will pick it up in the next cycle, and we'll have that. And all that came out of the data because we could see what was happening to these patients. So there's a lot of stuff like that where once you have the data, you can go in and begin to make recommendations.
Other questions? Should you raise your hand and push your mic, and if you can just state your name real briefly. Go ahead.
Mike.
This question is for I just want to call you Dr. P because I don't want to mess up.
Puckering?
That's one of the nicest things
Dr.
I've been called.
So I'm just curious to know how are you able to get the data? Like, are you getting, like, where is it coming from? Are the patients saying in all these zip codes, okay, you can use my data, or how is that being disseminated to this place?
So collecting health data, as I tried to intimate, is not an easy process. We started in 1998, and there were all kinds of rules and regulations that sort of prohibited. But we just decided we were just going to be absolutely persistent. That whatever the obstacle, if it takes us 5 years to get the data, it takes us 5 years to get it. We've been successful in getting access to 100% of the Medicare and Medicaid files. And also, we've developed a lot of relationships with insurers. So we have access to the commercial data like Optum data, et cetera. I don't know if there are other minority organizations like us out there. I've not met them, but we're one of the few minority organizations that are in that big data world. And once you're in there, you develop all kinds of relationships that help you access data.
If there are no other immediate questions, just to pick up on that theme around data and something that you mentioned, Dr. Puckering, around the treatment might be different for one population versus another. And that lends itself to my next question around clinical trials. How do we talk about, message, or begin to advance more minority and underserved populations participating in clinical trials so we can surface maybe the differences that medications have on different cultures or different populations? Can you just say a little bit about that? And Dr. Lubin Johnson or Dr. Costos, you're welcome to join as well.
So we've actually spent a lot of time thinking and working through clinical trials. And again, it's a number game. So prior to the Affordable Care Act, 48% of African Americans had no health insurance. 54% of Hispanics had no health insurance. And so when you went to industry, as we did, we went to the pharmaceutical industry and say, we want to see more minorities in clinical trials, we want to see more work done, and they would say, they can't buy my drug. They would say, yeah, it's a wonderful idea, we love health equity, but they literally can't buy my drug. And when you go look at the data, when you go back and you look at Lipitor, 90% of people were whites who were using Lipitor. So the Affordable Care Act changed that, right? And so for the first time, with all of its flaws, they had the card that gave them access. So that stimulated the pharmaceutical companies anyway a little bit. The other big thing that's happened is the demographic shift. So 2020, 40% of the US population will be minority. A drug going into clinical trial today, when it comes out, it takes about 15 years before it gets approved. The majority of people in the country who are going to use the medications are going to be minority. And so there's a clinical imperative now to make sure that those patients that are going to use the drug are in the trials. And so that's driving industry to really think about the market. And think about it for a second. If you look at California, it's flipped. Texas is essentially flipped. Florida has flipped. New York has flipped. These are large pharmaceutical markets. And so these are business decisions that are being made. And so when we talk to, yes, we talk about health equity, but really what we're talking about is an emerging market that has to be serviced. And it's also important for the American Medical Association. Your physicians are going to be treating minorities. And so it's really important that you have great relationships with those communities and understand the data and science that comes out of those clinical trials. So this demographic shift is going to have just tremendous implications for medicine. Clinical trials, workforce, you name it, it's going to be all over the place. And so we're in the middle of that paradigm shift, and it's happening.
Others want to comment on that?
Sure, I'd like to comment on that. So, I'm a very active member of the American Medical Association. I serve on the Women's Physician Section Governing Council, and I am also a very active member of the National Medical Association, and I'm president-elect, and I'll be the 100th president-elect. And I say that because the National Medical Association has had a grant and a program for several years to encourage our members to become investigators for clinical trials and also to encourage our patients that we serve to participate in clinical trials. Dr. Puckrin alluded to a medication that's used, actually has indication for use in African Americans in congestive heart failure. And that actually came out of a clinical trial that wasn't initially for African Americans. That combination for congestive heart failure called Bideal came out of a trial that was done predominantly for all, but the subset of African Americans was found to do so much better that they went ahead and did a trial, a clinical trial, that showed African Americans who use Bideal do much better than those who don't in terms of decreased hospitalizations, decreased mortality also. So participating in clinical trials is very important. And like you said, you know, we're going to a minority, you know, population. I like to call persons of color soon. And so we don't have enough physicians who are of color to say to recommend the patients to participate in clinical trials. So we've got to have culturally competent physicians who can talk to patients about participating in clinical trials and the benefits of it. You know, you get to messaging. You know, most in this room are, you know, familiar with Tuskegee experiment. We've got to get beyond that. And we've got to get our patients to know that there's benefits to participating in clinical trials because, you know, your participation, your family members' participation, it may not benefit them directly, but it could benefit those who come behind them. Yeah. So we've got to get the word out that participation is necessary. Yeah.
Dr. Bustos.
Just one point regarding data. Yeah, it's very hard to get the data in minorities, especially Latinos. A problem with home is an issue. We have problems getting the bills paid because the patients change address. And they have to fix it at some level. So sometimes if they change twice in a year or one time, just because they have to downgrade to the cheapest room that they can afford. That's one thing. So regarding studies, yes, I think that if the patient sees you as a friendly face that understands their needs, they will probably accept that. My personal bias, if it's an NIH study, I'm 100% for that. And as a member of Alivio, I will encourage everybody to participate on that. Pharma, I'm not sure about
that. And on that note, no. So, Dr. Rohack, you have a question as well. We're going to open it back up. We have about 7 minutes left, so if you have a burning question, we'd love for you to pose it to our resident experts.
Well, just to clarify, Dr. Pucker, I'm from Texas, and when you're talking about flipping, you're not talking about political yet.
No.
Okay.
No.
But my question is actually to the two clinicians. You know, the AMA has spent a lot of resources creating Health 2047 and working with Matter of applications and tools to help physicians and patients. But as I reflect on that, will those tools really get at a minority population that may not use smartphones or may not use clinical apps or other sort of things? So if you could comment about what do you see the AMA's need to help the minority population for tools to help that population at highest risk for diabetes and other chronic diseases?
Yes, I think that high tech is not going to work that easily. The patients, they are on Facebook all the time. And they are my kids are telling me Facebook is so outdated and useless. But that's what our patients are checking. When I come into the room, they're like, and that's what they mentioned. So to get a Facebook active, I guess you have to put like 3 publications every day. So you have to have the personnel ready there with information for them to read. Otherwise, all the friends, pictures, and everything will just bury that. The applications are too cumbersome for them. So if you ever want to try a new application, don't test it on the doctors and the nurses. You have to have the pilots with the people. The literacy in the Latino community is not as great as in other communities. I'm talking especially the undocumented that is a large part of our community, and they are not dumb. You can teach them how to use insulin and titrate insulin. They can know what A1C is. They can copy the numbers on the glucometer into a page. You can do a lot of work if they understand what you are telling them. But the apps, test them with them first, big pilot, and get the feedbacks. And you cannot test them with the representative of an organization. That organization has to go down to the field, to the church, to any other community promotoras, things like that, and get the feedback from them. Once you go to college, you are biased.
So I think that newer applications can be beneficial. You know, the studies show African Americans per capita have more cell phones than anybody. And so that's a population that could truly benefit, you know, and smartphones in particular, from applications. But I think he's correct in that they have to be tested on those populations. Now, I'm going to do a not so shameless plug in that you can take this to Mather, and this is somewhere they can go, okay? I belong to one of the largest churches in Chicago, as you see on my bio. We now, another Trinitarian in the house, all right. that makes 3 of us at least, okay. Last month, February, we ordained in our denomination the first digital media pastor at our church. And so she conducts classes for anyone who wants to go on how to use your smartphone, how to get on Twitter, how to get on Instagram. And so if someone with an application wanted to come there and train her to train others on that application, then then you have a way for some benefit. And so I think that, good point of taking it to those who you want to use it, because I think there are some good, tools there that you can put in, what you've eaten and the carb count and how much exercise you need to do to burn the calories that you need, keep track of your blood sugars, etc. There are some glucometer devices now where it's not so much a meter, it's a patch you put on, goes to your smartphone or the cloud, and then it gives you, blood sugar readings. So there's continuous glucose monitoring. So there are a lot of applications that can be beneficial, but I think it has to get down to the level of the patient. No, you're right. I don't want to be tested on it. I'm not the best person. My staff's not the best person, but the patients who are going to use it, there are definitely some great applications out there.
Yeah. And so we're about 3 minutes to the hour. So if there is someone with a burning question, we'd love for you to ask it of our panelists and give them opportunity to close out. Obviously, digital health solutions are something that the AMA is being very thoughtful about, and doing that in ways that obviously takes the patient in mind and where the patient is. So thank you for surfacing that, and thank you for your great words today. We're going to turn it over to Anna Lynn to give us a final comment or final question, and then we'll close out for the day.
I've enjoyed very much hearing from all of you and the questions as well. I wonder what final comments you would have for us about what AMA could or should be doing that it's not obvious that we are.
Not only in celebration of National Minority Health Month, but in general as well. Yes, please.
Promotoras. So there are different levels of educators in the community. You can have the health expert in the community with a degree in college. If you go to college, you expect some payment, some amount of earning a year. So they won't be able to do all that job. We won't have enough of them. You have to work with the lay people, the peers, that are the leaders in the community. There are plenty of them. The problem is that the finances is very temporary. They only get $1,000, $5,000. What can you do with $5,000 for a year? 10,000, 1,000. So start thinking about promotoras in the Latino community. The fight is the promotoras are not certified. If many of them are undocumented persons, they cannot usually go to college. They cannot get any payment. So when the promotoras are doing work, they are doing either because they are volunteers, or because they are getting stipends. The maximum stipend that they may get maybe $5,000 a year. But what motivates them is the work that they do there. They get that satisfaction. Some of them might keep going up the ladder. For example, those promotoras that are bilingual, those promoters that have citizenship with a social security, we have to give them college education. So then they can supervise the other ones, and we have to start pulling them up from the ground and trying to get them to teach the rest and supervise the rest. But it's grant money. Don't send petty cash.
So we've got promotores and Dr. Lubin Johnson, if you can give us one thing we can do.
So I'm going to speak to the need for helping us to have more physicians, and not just the pipeline, but recent data that shows female physicians make $100,000 less than male physicians. How do you expect us to continue to want to practice with that kind of disparity? African American physicians make $50,000 less than other physicians. And so it becomes a challenge to want to work as hard or harder to take care of sicker patients and populations, knowing that you're making less money. And so my ask is that AMA begin to deal with the challenge of pay disparities, just like we dealt with equal pay, equal work, albeit too late in the state of Illinois recently. I think we've got to deal with it with the level of our physicians too, because when we talk about disparities in healthcare and who's going to be there to take care of us, I'm gonna be honest. Studies have shown female physicians and physicians who look like the patients they serve take better care of the patients. And so that's what you want, is the best care for patients. So that's what I'd like to see.
And Dr. Puckren. Oh, yes.
Thank you.
Final word.
You know, I think one of the most important things that has to happen in this country is a reframing of how we think and what we think healthcare and health is. We still have a bit of a 20th century frame of mind about it in terms of what we have capacity to do in terms of improving health. And I think the American Medical Association can play a really important role in that conversation. It obviously is one of the most respected voices in healthcare. But you have to say out loud that there are people around the country who believe that their neighbors shouldn't have healthcare. That they believe that, they just fundamentally believe they shouldn't have health care. And they vote that way. And we're not going to be able to really provide quality care across the system if everyone does not have access to health care. That's just flat out not going to happen. And the realization of it is, any of us go into any healthcare facility, pharmacy, hospital, physician's office, the first thing they ask you is, let me see that insurance card, because that's going to tell me what I can give you, how long I can give it to you, who can give it to you, etc.
Where are you going to get it from?
Absolutely. And so if you have diabetes and you don't have health insurance, you're dead. Just be honest about it. And so I think AMA has to use its voice here. And it's fraught with trouble, I get it, but you're the most respected voices in our community around healthcare. And you just have to push back and say, we can't have really a quality nation if we're going to let 48 and 50% of our people walk around without health care and believe that we can give them rescue care when they come to the hospital. It's too late for that. So if I was advising, and I live in Washington, so I'm always hit with these policy issues. I know you're doing it, but I would say you've got to do it louder, that you just got to draw the line that everybody's got to have health care.
Yeah. So if I can quickly summarize those 3 points. The AMA was an early adopter and supporter of the Affordable Care Act, but we've got to do more and do louder. If we want physicians who are in the field who will probably be treating those who are disproportionately infected, whether they be women or physicians of color, we've got to make sure that they're compensated equally. If we're going to do care with underserved populations, we have to think about care extenders, community health workers, promotores, or others that can help to translate, to help with the health literacy issues that are at play. Those are 3 very powerful recommendations to all of us to do better. And then we can do that, right? Yes. All right. We can do that, right? All right, let's give them a round of applause. Thank you, everybody, for coming. That concludes our day. One more round of applause for our special guest. Thank you.